قدامنا دلوقتي كيس ستوري من خلال استاذنا الفاضل الدكتور عبد الكريم. يا ريت كلنا نتعلم منها ونسمع. اتفضل.
Before 3 months, of course, in our duty, I'm not in the hospital, but I'm almost in the background. There is a young doctor who is in the emergency department, and he received a young male, 29 years old, admitted from the emergency as severe convulsion, not respond to medication, and they decide to make a CT scan. And of course, after intubation, because the vital signs, all of the vital signs are very bad due to strong convulsion. And when the patient comes to us, of course, this is here in lying down in bed, and the quality is not very well. Patient is intubated, and this is here the CT scan. I select just 6 pictures of the first CT scan done for the patient without contrast media, and you say that there is hyperdense structure surrounded by hypodensity in the temporal loop. It's really in the temporo-occipital region without significant space occupying mass effect. If you can see the picture, there is another very small spot which is hyperdense. I don't know how's the quality of the picture with you, but at least you will see this lesion. I don't know if you see that very well. And they didn't phone me at the same time. They write that as intracerebral bleeding. Of course, I know that there is a lot of a patient who have intracerebral bleeding, even when it's bigger than this, will not go to severe or deteriorated situation as this young patient, of course, because there is no compression of the ventricles and there is no rupture to the ventricular system. I mean, it is small bleeding when it's bleeding. Anyway, it's still hyperdense. It was suspect of bleeding. And this is here the another pictures. We say that this is here an hyperdense lesion, and the surrounding area by the CT scan can be due to focal atrophy as example, and the density is very hyperdense, can be like bleeding, and we do control because they say that this is here because the patient is suddenly convulsion and after that comatose, and they ask for controlled CT scan, and we do the controlled CT scan, and it was the same. There is no change at all, at least for me. I didn't see any change. I'd say it's okay. This is here a case for further investigation, and we need anyway the MRI. The patient was, of course, in the ICU, and we are able to do the MRI without any problem, of course. And this is here the MRI. I think you will be surprised that this is here completely different than the previous pictures, because in native CT scan, I mean CT scan without contrast hyperdense lesion, there is a lot of hyperdense lesion, and it must not be bleeding. It can be, of course, the diagnosis was cavernoma and secondary bleeding of the cavernoma, but even when it's cavernoma and secondary bleeding, it will not cause the problem. Coma after severe convulsion. And what we appreciated here with the contrast MRI, this is in coronal, sagittal, this in coronal, you will see the lesion is here posteriorly. This is ring enhancing lesion. There is enhancement. And in the CT scan, it was hyperdense, it was partially calcified. Of course, it can be tumor, it can be metastasis, ring enhancing lesion. Of course, you know that the abscess and the granuloma and the abscess can, but we found that there is no space occupying mass effect. It's not active abscess, and this is even an additional problem. As I told you, the patient, there was change in the report. I say it's okay. I saw that the lesion with contrast enhancement and irregularity of the border. And we have such cases, of course. I thought on a TB. Our colleague who was there, young radiologist, I told him, please, change in the report. I'm sure that the cause of convulsion can be this, but the coma, maybe there is any other factor for that, or severe convulsion itself. Anyway, we put in our differential diagnosis inflammatory partial calcified granuloma. And I put in my mind the tuberculosis brain TB because I do more than one study, some of them published in TB, brain TB, central nervous system TB. And they told me, of course, can be something else. I say, yes, of course, any other inflammatory process, but TB is with irregularity of the border. This is one of the most important features. Thick wall, irregularity of the border, no specific mass effect, calcification, and biogenic abscess is well defined, regular, and the edema is very more. And I told one of our assistant doctor to start to write case report to publish it for a TB. And she asked me, she is from one of Arab countries, she is from Saudi Arabia. Can we do that later when we have all the materials? I say, start to prepare and then we will see. We can change that. And then, of course, they send the patient to another hospital, which is only neurosurgical center, which is not far away from us. And they do the operation, as you say, this is after a craniotomy, and they say it's not tuberculosis. What you think, what can be? Really, we put in our diagnosis the correct diagnosis, which come by the histology in our differential diagnosis, but not the first. We put it second.
ده سؤال كويس. سؤال كويس جدا.
It was toxoplasmosis, really. It was toxoplasmosis. It was toxoplasmosis. Really, the patient have granuloma. We was not far away from the diagnosis, but the histological examination, of course, it's come at the end. What's mean that? Professor Ahmed asked me to give his case, to give a case which we lose the problem. Really, what I want to tell you, we learn every day, sometime from you, and sometime we have to wait for the further investigation. Whatever is it in our department, like the MRI, or in another department like the histology, for sometimes the cytology is enough, but in another cases, or in some cases, we need real histology, and it was toxoplasmosis. Really, by drug abuses and lot of medication, and this same to be easy case from the beginning by the CT scan, but the result was surprise for us after we saw the MRI. And that's mean we can make mistake. Every one of us make mistake. But at the end, if we follow the case, of course, at the end, we have to change in the case report everything from A to Z. Really, to start again, we have only the material, the paper, the name of the patient, and the pictures. Everything else will change. But we learn from that. And this is here my
very يعني حقيقي very good case, and it is to the target. Our target is to deliver your experience to the juniors, how to deal with a case like that. You put an example, you put from the start ordinary differential diagnosis, then step by step, at the end, you follow up the case, you tell the feedback, you correlate with the findings of the histopathology, and you said that you learned from histopathology. You make a team with your colleague doctor with you. I think you said من سعودي عربيا. يعني انا عايز اقول بقى ادرس اللي انا عايز اقوله في البرنامج ده، اللي هو ما حول الحالة. بداية دكتور عبد الكريم جات له الحاله، مش الحاله جت بالهيستوري. يعني حضرتك يا دكتور يا جونيور يا مبتدئ يا دكتور يا اللي بتشتغل حتى الان زي حالاتي، ابتدي بالهيستوري كويس جدا. 29 سنه ميل بيشنت. بس كان ليا سؤال دكتور عبد الكريم، كان نيجرو ولا كان من السلاله بتاعته كان راجل عادي؟
لا والله من السلاله
الالماني يعني بادي بيلت محترم يعني. ما فيش حاجه في الهيستوري كده نعم. تاخدنا ناحيه الهيستوبلازموزس؟
الواقع اللي هو
الدراج ابيوزز. يعني طب علاقه الدراج ابيوزز بكده ايه؟ هل الاميونيتي ولا؟
بالضبط، احنا قلنا انه ولذلك وضعنا الجرانيلوما اللي هو اول ما شفت اللي هي الحاله قلنا جو اواي فروم كاذرنوما. كان
اللي هو ايه اللي خلاك تروح معلش ايه اللي خلاك تروح للجرانيلوما؟ اللي هو الرينج انهانسمنت.
الواقع الرينج انهانسمنت والريجولاريتي هو الواقع احنا عندنا main diagnosis ring enhancing lesion, especially when it's multiple, we have to think in metastasis or infection.
يعني ايه برضو انا معلش انا اسف بقطعك في الكلام، لكن عايز اوصل رساله للشباب. بي سمبل، common is common. ده في الاول لازم تفكر في الاول common is common. خد الحاجه الكومن. احنا ريجولار بنقول ايه؟ رينج انهانسمنت في ميل في كذا، بنفكر في ميتاستاسيس في ابسس. طب رينج انهانسمنت الريجولار ومكانه مش عارف ايه، ابتدي فكر في الايه؟ في الرير. ما تروحش للرير قبل ما تروح للكومن. وده اللي عمله الدكتور عبد الكريم، راحوا للكومن وحطوه كاستادي في الاول وبنوا عليه كلامهم. اتفضل يا بيه كمل.
الواقع نعم احنا بنينا كلامنا الواقع بعد ما سمعت الهيستوري وقرأت اللي هو الملف السابق ان المريض اللي هو admitted to the hospitals الواقع not only our hospital but to other hospitals due to drug abuses. والواقع انه كان ياخذ اللي هي الكورتيزون فور
ممتاز. يعني كل ده بيصب في ايه؟ في الهيستوري.
في هذا الحالة
كل ده في الهيستوري. حضرتك اهتميت بالهيستوري. يعني حضرتك يا دكتور الاشعه ما تكتبش اشعه لما تروح للهيستوري يعني معلش عشان بس في شباب صغير بيحصل ايه، ولسه الكلام ده معايا بالامس. الدكتوره قابلت المريض وما هي بسرعه لا 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 حضراتكم يا شباب بعد اذنكم ادي وقت للمريض واسمعه ودور على الهيستوري اللي جاي معاه. ومن المانديشن من حاجه المانديتس انك تحط في الريبورت بتاعك البريفيس ستاديز او الكلينيكال ستاتس، كل ده هيستوري. فانت معلش انا اشكرك دكتورنا الفاضل ان حضرتك اهتميت بالهيستوري وبتعلم الشباب يهتم بالهيستوري. تاني حاجه خدت الكومن از كومن وما حيدتش الاساسيات اللي بنمشي عليها في تشخيص الاشعه. بعد كده دكتورنا الفاضل انا اللي بس بركز عليه جدا مهم ان كان في تيم. الدكتور عبد الكريم مع انه كبير في الاشعه معاه دكتوره صغيره في السن اي ثينك صح كده بيه؟ كانت اصغر من ولسه المهم عمل تيم معاها وفكروا يعملوا كيس ريبورت. دي نصيحه تانية للشباب بعد اذنك، سجل خطواتك، سجل حالاتك، ابتدي اعمل ايه؟ اعمل البيبرز بتاعتك، اعمل الكيس ريبورت بتاعك انت بخبراتك. كلما يا بس بي مايندد بكده، لو مش مايندد مش هتعمل كده. بعد كده دكتورنا الفاضل تابع الحاله، وبعد ما تابعها بعد العمليه ركز معايا. هتقول الكلام ده بيحصل في بلاد بره ولا لا بيحصل عندنا بس محتاج منك شويه تعب، وبيحصل في معظم مستشفياتنا محتاج منك انك تبقى مايندد بانك تتابع الحاله بعد ما تعمل عمليه وبعد الهيستوباثولوجي بتاعها. كل دي ده اللي احنا عايزين نخرج بيه في كلمه كيس ستوري او كيس ستادي، ان احنا نوصل لكم الايه المانجيريال رول في انك تعمل سولفنج للبروبلم بتاعه الحاله اللي بتقابلك في الاشعه. فده كان الكور اوبجكتيفز بتاعت ان احنا نحط في فقره في البرنامج.